Good morning. This is really spread out this way. It's sort of interesting. Welcome to Department of Medicine Ground Rounds. I want to remind everybody that next Thursday, June 5th, will be Awards Day. And it will be, as I believe Jason just told me, is in this room. So this is an important time for our residents, and it's an important time for our faculty. It's a good opportunity to meet people and talk to them and see what people have been awarded with, because I think there's a lot of that everybody does that we don't always communicate, and yet they're important contributions to our operation and the life of this program. So really, come here next Thursday. It should be fun. A few couple of things about historical facts. And Henry Brackenhut was born on this day back in 1781. And he was best known because he isolated chitin, which is the most abundant polysaccharide in nature. But he also isolated glucose from plant stuff. So he would take sawdust or linen or bark, boil them into acid, and do a number of things that get glucose. And you say, well, that's not that important. But until then, glucose was only found from starch. So it really created a whole new, the beginnings of a whole new industry. But the interesting thing to me was that on this day was the death of Julius von Sachs. And Julius von Sachs, this was in 1897, by the way, and he studied plants. And much of his discovery really informed plant physiology for the 19th century. And he discovered transpiration, which is how waters are absorbed into plants and they move up in tubes without the cooperation of cells. He discovered chlorophyll. He discovered that chlorophyll was important for the development of glucose and then storage into starch. And he actually did a lot of work in tropism, how light and gravity actually affected the movement of plants. So again, very influential in the area of plant physiology, which ultimately had importance in our understanding of biology of humans in many other ways, and so that's important. But yesterday was Maya Angelou's day, okay? American author and poet who died yesterday at age, I think, 86. She was born in St. Louis. I didn't know that. I knew she lived in North Carolina. But she was born in St. Louis. She was nominated for the Pulitzer Prize and a Tony Award, had 3 Grammys for her spoken word work albums. He won the National Medal of Arts in 2000, the Lincoln Medal in 2008, the Presidential Medal of Freedom in 2011. There's a lot been said about her. I'm just going to mention one quote that I like, and then I'll introduce our guest today. But she said, "I've learned that people will forget what you said. So everything I said today, you will forget. People will also forget what you did. Everything you have done, people may forget. But people will never forget how you made them feel." That is very true. And I'll leave you with Chris Kruger, the Division Chief for GI, who's going to introduce our guest.
Well, it's my pleasure to introduce to you Jason Ray Roberts. If you haven't met him, he's been here only about a year, so I've put him up as an assistant professor to give a grand rounds. But I'll tell you, when he came in the door, he had 6 book chapters. He had 5 full publications and 12 abstracts, as well as multiple presentations. So he's already made his name as a premier teacher. He graduated from the University of Kentucky with magna cum laude. When he was an intern, he was named the Intern of the Year, and he won teaching awards, I think, every year during his residency. Since he's been here, there isn't a nurse in the house that hasn't come to me and said, "I love him. He's wonderful. He teaches us." So let's give a round of applause when he comes up to hear a lot about colon cancer screening. Very important, since 1 out of 10 people are going to get colon cancer. Jason, thank you very much.
Hello, can you hear me? Well, thank you for the introduction, Dr. Roman, Dr. Kruger. Thanks for the opportunity to speak in front of my new colleagues today. As she's explained, she's thrown me in the pool, just my first year, and asked me to give medical grand rounds. Interesting that your comments about Maya Angelou and people not forgetting, people not remembering what you say or what you do. She clearly didn't know my wife, who seems not to forget those sort of things. But anyway. So I am a Kentuckian. I was born and raised in Kentucky, most of my medical education, and then I moved to Charleston, South Carolina, and I think I'm the only person to move from there in the last 20 years. So That's an interesting thing. So first of all, let's talk about disclosures. I have none to report. Certainly no conflicts of interest as it relates to this talk. However, I am conflicted. I owe the University of Kentucky a substantial amount of money, but their arch rival is paying me money. So, you can put a dollar amount on your loyalty, I suppose. So let's talk about the objectives for today's talk. We want to talk about several things. This is a lot of information, so I'll try my best to get through it quickly and without putting you to sleep. But we're going to identify what the screening population is for this disease. We want to identify high-risk individuals within the population. We want to compare various screening modalities and what their intervals ought to be. We want to recognize the importance of early detection of cancer, as it clearly has an impact on outcomes. We want to discuss the protection from proximal versus distal cancer with screening endoscopy and some of the debates that are ongoing about that. We want to also discuss quality in screening colonoscopy programs, as that clearly affects the operating characteristics of that screening test. So just some fast facts about cancer, and Dr. Kruger mentioned it does affect everyone, whether personally or through the patients you care for. And globally, it's the third most common cancer in men and second in women. In 2008, worldwide, there were over 1 million new cases and over 600,000 deaths. Here in the U.S. in 2012, it was estimated that just over 140,000 cases would occur and 50,000 deaths from those. Also, the incidence varies as much as tenfold globally and worldwide. And the reason, and what you see is in the highest incidence areas, you're talking about Australia, New Zealand, Europe, and North America. Whereas in the lower incidence areas, it's mostly undeveloped parts of the world, as in Africa and South Central Asia. And some of the thoughts about why this variation would include differences in diet, the environment, also genetics clearly play a role in this. And of course, we know that here in the developed world, we like our meat. And this is even something the universe realizes as aliens come and steal our cows. So maybe red meat plays a role in that. Clearly, there is socioeconomic risk, as the lowest quintile group has a 30% higher risk of developing cancer compared to the highest quintile. About a third to a half of this increased risk is felt to be due to inactivity or lack of exercise, also obesity and diet. All of these have an interplay, and smoking. The remaining risk is due to a lack of cancer screening. In the U.S., we have some good news. Over the last 15 years, we've seen a decrease in the overall incidence and mortality from cancer. The lifetime risk in the U.S. is approximately 5%. 90% of these cases are going to occur in people over the age of 50. Men are clearly at increased risk relative to women, and African Americans, in terms of the ethnic breakdown, are at increased risk. Asians and Hispanics have a slightly lower risk relative to whites. This is a graphic showing you the distribution of cases, and clearly the area under the curve is largest for that over 50 age group, with a median age at 68. If you look on the left, the numbers for the men are clearly higher than women, and among racial or ethnic lines, blacks have a higher risk relative to whites and Hispanics and Asians. So in order to tackle this problem, we have to understand how it occurs. So the colorectal cancer pathogenesis, or also called the adenoma-carcinoma sequence, you'll see in the top a cartoon where you get cellular proliferation, and as it grows in size, develops into an adenomatous polyp, which by definition has low-grade dysplasia. And then various levels of dysplasia can occur up to high-grade dysplasia and then frank adenocarcinoma. From a DNA level, you start with normal epithelium and you develop cumulative DNA changes, including changes to the APC gene, KRAS, BAT26, P53, and with those successive changes, you progress to cancer. So this is what gastroenterologists deal with every day. This is the bad player, and this is what we're looking for. On the left, you see a typical sessile polyp. This is a tubular adenoma. It's pretty obvious to everyone that that is abnormal relative to the rest of the colon, completely resectable with colonoscopy, and it should have clear margins and be essentially the risk of cancer should be removed. On the right is the other predominant form, which is a pedunculated polyp. It forms on a long stalk. All of the adenomatous tissue is there at the apex of the stalk. Again, this is my son, who's 8, could tell me that looked abnormal, and that should be removed. The problem, however, are these lesions. This is the other type of pathology that we worry about. These are sessile serrated adenomas. The problem with these is they tend to congregate in the right colon and the proximal colon. They tend to be less conspicuous. You see in A and B a lesion in the right colon. You see on the left with white light endoscopy a mucus cap. That's sometimes a telltale sign. On the right with narrow band imaging, which is a filter for the light. You can see differences in the vascularity. Again, in E and F, you see the same lesion under white light and narrow band imaging. There are subtle changes to the vascularity and the mucus cap which tip you off to that there's been a polyp there. However, if you're only looking for protuberant lesions that project into the lumen, you're going to miss these things. So you have to be a little more meticulous in finding these lesions in the right colon. Of course, when we miss these polyps on endoscopy or you don't undergo screening, in screening programs, this is what happens. You develop cancer. So colon cancer is nothing new. Certainly it was recognized in 1921 by Dr. Macaulay in the British Medical Journal that cancer in the colon is slow growing and that if we want to meet our responsibility to the public, we have to spend all of our effort to detect cancerous lesions in the earliest moment. So that's been known for a long time. So let's talk about the staging of cancer, the TNM classification. And what we consider early or non-metastatic cancers are stage 0 to 2, which are node-negative disease, and then stage 3, where you develop local regional lymph nodes without distant metastasis. The red box indicates the group of patients that we really can benefit by detection and treatment. Just briefly about the treatment in stage 1, you can undergo surgical or endoscopic resection. In stage 2 patients where they're surgical resection plus or minus adjuvant chemotherapy, in the data there's a little less benefit with chemotherapy when you have node-negative disease. I'm sure that's a debated topic among oncologists, but it's certainly something to think about. In stage 3, it's clear surgical resection with adjuvant chemotherapy should be offered. In stage 4, you can consider palliative therapy, or in patients with an isolated or focus of a metastasis to the liver or lung, you might consider an aggressive approach where you resect the primary and treat the metastatic lesion aggressively. Rectal cancer is a bit different, where there's studies indicating neoadjuvant chemoradiotherapy actually can reduce recurrence at the surgical site and is the standard of therapy. Again, this is a cartoon showing you early stage disease, which can be detected by endoscopy and resected for cure. We're talking about stage 0 or 1, where you have an adenoma or even a cancer that's limited to the limited to the mucosa or the submucosa and not invading the muscularis propria. Of course, when it reaches that point, surgical resection is not offered, at least not as standalone therapy. So overall, the 5-year survival for colon cancer in all comers is about 65%. And if you look at the breakdown at the stage at diagnosis, a substantial number, 20%, already have distant metastasis at the time of diagnosis. But the majority, in fact, are considered localized or local regional spread. And if you look at the 5-year survival data on the right in the bar graph, localized or regional disease, the majority of patients do pretty well at 5 years, whereas the survival is dismal for distant disease. Again, Dr. Macaulay had it right when he talked about colonic cancer is, however, the less virulent type of cancer, and it's to say that the rate of growth is comparatively slow, and invasion of lymphatic vessels and glands is relatively late. What that means is that we have a real opportunity at good outcomes when we detect cancer in the earliest stages. And again, here, this is a survival curve according to stage at diagnosis, and there's a clear association with survival and stage, with the distant or stage 4 with distant metastasis being your 5-year survival at less than 10%. So what are some problems with detecting cancer early? Well, there's several. And one of them is it requires the patient to have some sort of symptom to present to care, especially if they're not engaged in a screening program. And these symptoms can be nonspecific and often be dismissed by patients. So there's clearly a delay in patients seeking care. And then the same problems encountered when the physician has the patient in front of them. The symptoms are nondescript and can be secondary to other causes, and so the diagnosis may be delayed after they seek care. If you look at the symptom type and the frequency for colorectal cancer, it's clear that the increased, at least frequent symptoms are associated with lower GI symptoms, including rectal bleeding, fecal occult blood positivity, we'll see tenesmus is not a high frequency here, but on the other side in this study where they did a univariable analysis, tenesmus and rectal bleeding, altered stools, diarrhea, these things were all associated with a high risk of cancer. There are also multivariable predictors in this particular study where they looked at hemoglobin, rectal bleeding, constipation, and a proximal cluster of symptoms, which included one of several symptoms, anorexia, nausea, vomiting, abdominal pain, fatigue, and they were associated with colorectal cancer. So the problem is that these symptoms can be nondescript. Rectal bleeding in various patients, particularly when there's hemorrhoids present, can sometimes be a red herring and throw you off the track for looking for an occult lesion. So this is just general principles of a screening test. The condition's got to be an important health problem. Cancer fits that. There should be treatment for the condition. We're going to show you that. Facilities for diagnosis and treatment are available. We have that in the U.S. In other countries, it's more of a problem. There should be a latent stage of the disease. It's clear that patients are asymptomatic for a length of time. There should be a test or examination for the condition. We're going to talk about that today with screening. It should be acceptable to the population. The natural history should be adequately understood. That's the adenoma carcinoma sequence. There should be an agreed policy on whom to treat. We'll talk about guidelines. The total cost of finding the case should be economically balanced in relation to medical expenditure as a whole. This is what we debate about. And there's case finding should be a continuous process, not just a once and for all project. So let's talk about who's at risk. We'll talk about this a little bit later, but anyone over the age of 50 is considered at least average risk based on their age. The decision to treat individuals over the age of 75 is a hot topic, and it really is based on a discussion with your patient, their comorbidities, and their life expectancy. High-risk individuals include multiple folks, and those that are in the hereditary cancer syndromes like FAP or Lynch, personal family history of sporadic cancer or polyps, inflammatory bowel disease, particularly UC. Abdominal radiation as a child, interestingly, increases your risk of lifetime colon cancer above the population. Race, particularly African Americans, there's some debate about whether we should offer screening to this population earlier than 50, perhaps at 45. Acromegaly, interestingly, has a slight increased risk of lifetime colon cancer, and renal transplantation, particularly early in life where you may be on long-term immunosuppression. There's data for these things, but they don't really affect guidelines to date, at least not for the bottom four. So what are the available tests in the U.S.? Well, we have two categories, really. One are fecal tests, and they're best at detecting cancers, less good at detecting neoplastic or precancerous precancerous adenomas. And then you have structural exams, which are best at detecting precancerous adenomatous polyps, but also early cancers. And those include the flexible endoscopic exams as well as double contrast barium minima and CT colonography. So let's talk about the pros of fecal tests. So up on the right corner, you see the standard guaiac-based fecal stool cards. And something that I discovered in giving this talk is there's actually a proper way to collect the stool specimen, and that is have the patient sit on the toilet backwards. And that's why most of you aren't in GI. You don't talk about potty talk too much. So the issue here is that the stool specimen is not in the water, so it's more easily collected, and that's a helpful thing to tell patients. But what are the pros? Well, it's inexpensive, that's clear. It's non-invasive unless a positive test kicks you over into endoscopy. There are no risk, again, unless you have to have endoscopic evaluation. But sitting on the toilet backwards might have some risk, I don't know. Can be completed in the privacy of your home. That's important to a lot of people. There is no bowel preparation required. That's also important to people because that's the worst part of endoscopy. There are some cons, however. So it's less likely than invasive tests to prevent a cancer. So you're detecting cancer, not necessarily precancerous lesions that you can intervene on. It requires testing at regular intervals to be effective, and this is important because adherence to screening programs with yearly testing are pretty poor. Positive results do require invasive tests, so that's important, and proper recommendations of test results are also important. So let's talk about structural tests and what the pros are here. They prevent cancer by detecting and removing precancerous adenomatous polyps, and this is particularly relevant to flexible endoscopy, not to the imaging modalities. There's a longer interval between tests, especially when you consider a quality negative colonoscopy, which has protection out to 10 years and beyond. We'll talk about that later. Clearly, there are cons. They are relatively expensive compared to the fecal test. This is an issue when you talk about resource allocation. There's a greater associated risk, particularly with perforation and bleeding in the event of doing a polypectomy. Rectal intubation is required. That's a big issue for particular patients. It can also be uncomfortable. It requires a visit to the office or the hospital. And they all, unfortunately, require bowel preparation. If anybody can come up with a tolerable bowel preparation, you won't have to work anymore. So interestingly, in Germany, they found a way to advertise colon cancer screening to skiers. You're out skiing and you see this sign, you're like, oh yeah, I need to get my colonoscopy. They're pretty smart. So let's talk about the guaiac-based fecal test, okay? This detects heme through a pseudoperoxidase reaction. That's the reagent that you're using on the card. Patients should avoid, however, certain things to improve the test characteristics, and those include NSAIDs, vitamin C, as it can block the reaction, red meats, poultry, fish, and cruciferous vegetables. Proper sample collection includes 2 samples for each of 3 consecutive stools, and this is another issue with the test being done properly. Samples are processed in the office or in a laboratory. They should be rehydrated for improved sensitivity. So some of the characteristics, we have 3 randomized controlled trials showing a 15 to 33% reduction in mortality. An additional study showed an incidence reduction of 20% after 18 years, so long follow-up. Sensitivities for cancer vary from 37% with an unhydrated sample, and in that study they used the Hemocult 2, to as high as 79% with a highly sensitive assay, the Hemocult Sensa. The Hemocult 2, which has lower sensitivity but had higher specificity, was compared to the highly sensitive Sensa, which, as you would expect, had a slightly lower specificity. There are certainly limitations, and this is probably one of the biggest detractions from this modality. Only a third of surveyed physicians performed screening guaiac tests up to a third of physicians performed the test by doing a rectal exam to obtain a specimen in the office and guaiaced it there. That's incorrect. Another 41% used a combination of the in-office test and a take-home method. Up to a third of those using the in-office test, once they developed a positive test, they then repeated that with another test, and that's not appropriate and it goes against the guidelines. And a substantial percentage referred positive tests to a flex sig, and that works if you know the bleeding only came from the left colon. This methodology yields a sensitivity for advanced, that was a joke. This methodology yields a sensitivity for advanced neoplasia of only 5 to 9% for colorectal cancer. So clearly, this is more of a real-world take on how the test is performed. So we have a lot to do about educating people about how to appropriately screen folks using the guaiac-based test. Now, the newer kid on the block, at least in the U.S., is the FIT test, or fecal immunochemical test. It detects human globin. So you have less false positivity rates because of the pseudoperoxidase reaction that you get with meats and fruits and vegetables. Vitamin C does not cause a false negative test. And it has increased specificity for lower GI blood loss because the globin is degraded by digestive enzymes from the upper GI tract. So it doesn't have some of the same pre-test restrictions that you place on the guaiac-based test. There are some interim results from a Spanish randomized controlled trial comparing colonoscopy to biennial FIT. Now, this is important because current guidelines in an endoscopy-based, at least colonoscopy-based screening program does not recommend interval testing with fecal tests currently, okay? But in this test, participation with FIT was higher than colonoscopy, as you would expect. It's less invasive, easier to do. Colon cancer detection rates were similar for both. Colonoscopy detected more advanced adenomas, 2% versus less than 1% for FIT. But colonoscopy detected more non-advanced adenomas, again, probably a predictable outcome. High-risk patients with family history of colorectal cancer or personal history of neoplasia who had undergone 2 previous colonoscopies were offered annual FIT between interval colonoscopies. So this gets into the issue that we should discuss. FIT sensitivity for colon cancer and advanced adenomas was 86 and 64% respectively. Colon cancer and advanced adenomas in the FIT group were diagnosed nearly 2 years earlier. Patients with repeated negative FIT had a twofold decrease in risk of colon cancer and advanced adenoma. So this raises some eyebrows, and perhaps we should look more closely at whether we should do interval testing with a less invasive modality like FIT in between colonoscopic examinations. FIT's emerging as the preferred fecal screening test, but there's multiple manufacturers, so with different performance characteristics, so deciding which assay is best is challenging. The optimal testing interval is unclear, but currently most guidelines recommend yearly testing. What's the optimal cutoff for quantitative assays in terms of hemoglobin quantity is still not determined. There's concern that cess-ulcerated adenomas in the right colon, which tend to be hypovascular, may be missed by fecal occult blood testing. So now fecal DNA, and this is exciting. It seems to be exciting because it seems to be technically a more robust test. It looks for chromosomal instability abnormalities in the stool by detecting KRAS, APC, and P53 abnormalities. Also, the BAT26 is associated with microsatellite instability, is another portion of the test that's looked for. DNA integrity assay assesses dysfunctional apoptosis. So there's three aspects to fecal DNA testing, so it's actually a battery of tests, essentially. Exact Sciences, which is a industry-sponsored multi-center study in 2004, compared guaiac-based tests to fecal DNA and colonoscopy. Fecal DNA sensitivity for advanced adenomas was superior to guaiac-based testing, but was only 50% sensitive for cancer. There's been subsequent studies in this space where improvements in DNA retrieval have yielded higher cancer sensitivities, ranging from 70 to 87%. There still remain questions regarding the optimal testing intervals for fecal DNA. There's a lack of data for colorectal cancer incidence and mortality reduction in true screening populations. Most of the data come for patients who are known to have cancer or high-risk polyps. Current cost estimates for this technology are higher than the yearly yearly fecal occult blood testing, FlexSig every 5 years, or current colonoscopy recommendations. So there's some limitations to that. Very briefly, I'm going to talk about CT colonography because of time, and also because CMS declined to approve this for a screening indication, and they cited several factors: lower detection rates for small polyps, less than a centimeter, a high colonoscopy referral of 30%, radiation exposure from repeated testing, although they've worked on reducing levels over the years, high rates of extracolonic findings, and the downstream risk of subsequent diagnostic testing. And also they cited the U.S. Preventive Task Force, which did not recommend CT colonography for similar reasons. You should know, though, that there are several societies, including the American College of Gastroenterology and the American Cancer Society, that do recommend CT colonography in their guidelines at intervals of every 5 years, similar to FlexSig. So now let's move forward to flexible endoscopy, and we'll talk about FlexSig, which has been around for a long time. We typically use a gastroscope, which is approximately 60 centimeters long and less than a centimeter in diameter. The extent of your exam traditionally has been the splenic flexure, but in a lot of studies it may only be in the descending colon. A gastroscope can reach the cecum, actually, in a fully prepped colon. The issue with most exams is you don't fully prep the patient. This is just a cartoon showing the extent of your scope up to the splenic flexure, which is there on the right. And the typical business end of the scope shows a video camera, which has a video chip in the end of the scope, an irrigation port, your light source, and an instrument channel to go down and biopsy or remove polyps. So here are 4 randomized controlled trials showing the effect of colorectal cancer incidence and mortality with FlexSig. The top one by Hoff in Norway initially showed no significant reduction in the incidence, but when they looked at a per protocol analysis with adherence to screening protocols, they showed a significant reduction. These are all intention to treat analysis, hazard ratios, and relative risk reductions. But the other 3 clearly show risk reduction in colorectal incidence and mortality. I'm showing you 3 of these slides from 3 of the studies which showed the colorectal cancer incidence relative to the screening and the control group. And I'm showing you this because they all look the same. You have an initial increased incidence in the screening group because you're detecting prevalent cancers. And then there's an inflection point 3 to 5 years later where your control group has an increased incidence of incident cancers, and you have a decrease in incident cancers in the screening group. So it's amazing that of the thousands of patients that they evaluate in these trials, they get very similar data. This is another way of showing the point, which is prevalent cancers are detected early at the time of screening, and then when you follow these people out, they have a decrease in the incidence of cancer. The U.S. Preventive Services Task Force recommended colorectal cancer screening with fecal testing in FlexSig in '96. And I'm showing you this picture because it's a bit of a timeline of screening recommendations. In 2001, Medicare actually approved colonoscopy for screening average risk population. So what you see is a divergence in the utilization of these screening tests. On the top, you see an upward trend of the use of flexible endoscopy, whereas you saw a plateau of fecal blood testing that is now declining. And that gap is worrisome because we know that it's more expensive to use flexible endoscopy and there's fewer patients willing to undergo screening, whereas we have a good non-invasive, effective test that we're using less of, and maybe that's something that we should look at going forward. Colonoscopy does not reduce the risk of proximal cancer. Well, this is what we started talking about in the press in around 2010, 2011, and this is the reason. There were 4 studies outside of the U.S., 2 in Canada and 2 in Europe, which were observational case control studies. And what they showed is that similar to FlexSig, colonoscopy does protect from overall cancer incidence and left-sided cancer, but not in the right cancer. If you look on the right-hand column, the odds ratios are very poor. And so that was concerning. It raised eyebrows, and people that recommended screening colonoscopy without good randomized controlled data said, well, boy, if I knew this, I wouldn't have recommended that. And people were recommending we go backwards. But there's an issue with that, and I think a lot of the investigators that produced those results have gone back and looked at their studies more closely and have produced new results to try to clarify what they think is going on. And when you look at the Baxter study from Canada, there are a lot of physicians performing flexible endoscopic screening, and the majority of them are non-gastroenterologists. The completeness of the colonoscopy, which is defined by reach in the cecum, was pretty poor among all endoscopists. It's only about 80%. But they speculated that there are training differences that exist and that might explain some of the results. And in fact, if you look at the Singh study, again, a Canadian study, and you look at the box on the bottom, it breaks down the specialty of the endoscopist. And in the top, you look at proximal colorectal cancer deaths expected over observed, and also in the distal. And if you look at the proximal colorectal cancer, the mortality is lowered by gastroenterologists at 0.61, and it's not affected by non-gastroenterology endoscopists. The data for left or distal cancer protection is similar. So when you look at the subgroups, there is some differences in the risk reduction. Overall, we're seeing a decline in colorectal cancer resections. This is indirect evidence that screening is working. You see this sharp inflection point around 99-2000 and a little bit later for proximal cancer. So on the left is distal cancer. Overall, it's, the incidence is dropping in terms of resections, and in the right, the proximal cancer is dropping as well. These are long-term reduction in colorectal cancer risk with a negative screeningoscopy. So if you follow people without screening and those that were screened and had a negative exam, you can see an age-adjusted hazard ratio that's improved for patients with negative colonoscopy that goes out to as many as 15 years. So why is colonoscopy less effective in the proximal colon? Well, there's several reasons. One is bowel prep quality is worse in the proximal colon, and you can obscure small flat lesions. Cecal intubation indicating a complete exam should be at a high frequency, and it's not that in some of these studies that have been described. Inspection of the proximal colon is more difficult. There are deep folds, and the proximal side of the fold can be obscured. Polyps in the right colon are often flat and less conspicuous. And there's data on incomplete polypectomy. So you remove the polyp but leave some of it behind, which has an opportunity to grow. So bowel preparation is important, and we have now several randomized controlled studies. This is a meta-analysis looking at those, where a split dose prep, where you take half the prep the day before and half the prep the morning of your exam, actually increases the number of adequate prep examinations. And the Flores plot here shows that clearly there's a favor of split dosing versus taking the full dose the night before. Let's talk about cecal intubation. It's the holy grail for endoscopy. First-year fellows in a couple months are going to have a hard time doing that. And it's kind of why, I can't blame that. It's why I don't have any hair. But it really is challenging. It's harder than you think. So cecal intubation rates, when you get proficient, should be very high. And that's why I bring this slide up again. It wasn't very good in the study by Baxter et al. In Canada. This is somebody's ascending colon, and everyone in the room can see the large, flat, laterally spreading polyp there. This is looking towards the cecum, which is just beyond the polyp. So this is in the proximal ascending colon. You would have detected this as long as you got there in the right colon. The problem is removing the colon required retroflexion in the right colon and removing all the polyp. Many times there's incomplete resection of these lesions because you don't know what's behind the fold, the tip of the iceberg phenomenon. This skill of retroflexing the right colon is not routinely taught to gastroenterology fellows, let alone surgical or other endoscopists. So, but it is important to remove lesions in the right colon, but also to detect small polyps, because with a negative colonoscopy and allowing someone to go to 10 years, if you miss a cess-ulcerated adenoma on the back of a fold that has a high chance of progressing to cancer, you're going to have interval cancers in that situation. So industry has come to the rescue. They've come up with some ingenious ways of improving inspection in the right colon. This is called the endocuff. This is a low-tech, low-cost implement that goes in the end of the scope during colon intubation. The fins are flat against the scope. On withdrawal in the right colon, they grab a hold of the folds and pull them flat as the endoscope pulls across the fold, allowing you to see the polyps in forward view. This is called the third eye. It's an implement that gets passed through the treatment channel of the scope. You see in the bottom right corner, that's your retroflexed view as you're coming back. You see the scope looking at you. And then the left is your traditional forward view. The problem is if you find something, you have to remove it, go down and find the polyp in forward view and treat it. So this is high technology, higher cost, and higher complexity. This is the Fuse endoscopy system, which has a traditional forward view, but also two optics on an optic on either side of the scope, which gives you a retroflex view as you come back. This may induce a seizure in people that are susceptible because you're looking at 3 screens and you're trying to understand where you're at in the colon. And if you see a first-year fellow scope with 1 screen, it's hard enough. So that's not really going to be prime time anytime soon. So 10 to 27% of interval cancers are attributable to incomplete polyp resection. And this study shows that. If you look at the polyp size, the larger polyps tend to have a higher chance of having residual polyp tissue, and that's by biopsies after resection. If you look at the histology, the cess-ulcerated adenomas also have an increased risk. Again, they're flat polyps. Technically, they're more difficult to remove. And then anything that's removed in multiple pieces, or so-called piecemeal resection, clearly has a high risk. And we'll see why the guidelines require that we look at those people sooner. This is a separate study looking at 5 endoscopists included in the trial and looking at their polyp resection rates. Endoscopist A was really good at finding and removing a lot of polyps, and subsequently they must have good technique, or at least that's the inference from here, because their incomplete resection rate is very low at 6.5%, but there is quite a bit of variability, up to 22% if you look at these 5 endoscopists. Polyp biology of cess-ulcerated adenomas, it's truly unique and different than tubular adenomas. There's indirect evidence linking undetected SSAs to interval cancers. And the reason is interval cancers are more likely to be proximal. They're more likely to have MSI or the CIMP phenotype. The CIMP tumors often carry a BRAF oncogene mutation, not the KRAS that you see with the predominant sporadic cancers. And then SSAs consequently often carry a CIMP and BRAF abnormality, whereas tubular adenomas do not. So there's indirect evidence there. There's going to require more studies to look at this. we should be measuring our adenoma detection rate when you're endoscopist. And this is a very simple calculation. It's straightforward division. You take the average number of, you take the number of average risk screening colonoscopies where you detected a polyp, removed it, and the histology is consistent with an adenoma. Then you divide that by the total number of average risk screening colonoscopies. And your number in men should be greater than 25% and women greater than 15%. And this again indicates that men have a higher risk of developing polyps than women. Despite that being very simple math, it's very hard to measure because it requires resources. Currently, pathology databases don't communicate with our endoscopy note writing systems, so there's no way of generating easily a data mineable database. However, when payers begin to pay us based on our ADRs and patients shop around for doctors based on ADRs, I'm sure we're going to get a lot smarter about how to figure that out. So higher polypectomy rates associated with reduced risk of proximal colorectal cancer. Again, this is getting to the idea that high-quality endoscopy can be protective. And if you look at the polypectomy rates broken down by endoscopists, up at the top rather, less than 10% polypectomy rate, that's the referent group, but the highest polyp detectors at 30% show increased protection of proximal cancers. And then if you look at distal cancers, it's a similar phenomenon. Photo documentation is important. It's the only way to tell people you've been where you've been. So in picture A, you see the appendiceal orifice and the cecum, and there's no debris around, so you know that the endoscopist had the opportunity to get a good view. In B, that's a picture of the proximal ascending colon with the ileocecal valve in the distance. In C, you see the terminal ileum, which isn't necessarily required, but if you get in there, you know you've been in the cecum. And in D, again, this is the an often performed retroflexion in the right colon, which gives you good views of the proximal side of folds. So let's talk about the actual reduction of proximal colorectal cancer from case control studies. So these are same investigators involved in the previous studies showing no protection. They've gone back, they've controlled for colonoscopy quality and endoscopists. And what they've shown is that similar to the previous data with colonoscopy and FlexSig, there is protection in overall and left-sided cancers, but there's also a striking protection in the right colon, albeit less so than the left. So still there's problems in terms of an imbalance between the protection in the right and left colon. The good news is we don't have to depend on observational data forever. We do have 3 randomized controlled trials evaluating screening colonoscopy, and those data are coming with a long year follow-up, and those are in Spain, other places in Europe, and the VA here in the U.S. So let's talk about screening guidelines. So this is from the joint guideline of the American Cancer Society and the U.S. Multi-Society Task Force, as well as American College of Radiology. And these are the guidelines for people that are at average risk, so asymptomatic adults over the age of 50. And they recommend tests to detect adenomatous polyps in cancer, including flexible endoscopy, as well as the 2 imaging modalities we've discussed. They also recommend stool-based testing that are primarily geared to detect cancers at an early stage. So here are the screening and surveillance guidelines from this task force for patients who are at an increased risk. And if you look at the top left, patients who have a history of 1 or 2 tubular adenomas, that are slight increased risk, and so we scope them again in 5 to 10 years, assuming those were removed previously and they were adenomas. The problem is patient recall and records often are missing, and so the patient tells you they had polyps, but you don't know if they were hyperplastic or adenomatous. And patients with more polyps, 3 to 10, or those with high-risk lesions greater than 1 centimeter that had villous components or had high-grade dysplasia, we do bring them back sooner because they're at higher risk for interval lesions, and that is at 3 years. And then patients with more than 10, again, a sooner repeat exam and consideration of genetic testing, as they may have attenuated FAP or some other genetic predisposition. And the patients with sessile adenomas that are removed in piecemeal, we talked about that being high risk before. We bring them back in 2 to 6 months and relook at the area. Often we tattoo it and make sure there's no residual polyp tissue after healing has occurred. Patients with a history of cancer are at increased risk, and they should undergo an endoscopic evaluation to clear the colon for synchronous lesions so the surgeons know what the surgical field is. They also should have a repeat exam at 1 year from that time. And again, at 3 years, if that exam's normal, and again at 5 years after that, assuming that's normal, and then every 5 years because they're at increased risk for cancer. So 1, 3, and 5 years after a cancer. Patients with a family history, so those with a first-degree family member with a cancer or polyps before the age of 60, or those with multiple first-degree relatives, despite no matter what the age, should start screening at the age of 40 or 10 years before the youngest case, and then every 5 years because of the increased risk. Patients with a cancer or polyps in a first-degree family member over 60 or 2 second-degree relatives are considered higher risk, and so they get screened earlier, but then their subsequent exams are based on what you find and are based on average risk populations. So there's a high-risk group, and we haven't talked a lot about these. They're more of a specialized group, but they consist of the genetically group of FAP, where you're beginning screening early, and if you confirm they have the genetic disease, early referral for colectomy is recommended. Also, the Lynch syndrome group, you start screening at a bit lower because their risk is a bit lower, and you have frequent colonoscopies every 1 to 2 years and counseling for genetic testing, particularly for family members as well. And then the inflammatory bowel group that we see who had developed an increased risk of cancer, particularly lifetime cancer after they've had disease for 7 to 10 years, have frequent exams and are looking for dysplasia. So this is a separate guideline from the U.S. Preventive Services Task Force. And here they recommend screening in adults aged 50 to 75 years with either fecal testing or flexible endoscopy, and that's grade A evidence. In adults 76 to 85, they do not screen routinely, and that's a grade C. And then adults over the age of 85, they recommend do not screening. And so this is some of the reasons. They think that there's insufficient evidence to indicate a mortality benefit in individuals over the age of 76. But you and I both know that that can be a problem with their aging population, and more people are at that age group, and they may in fact be very healthy and have a life expectancy greater than myself since they've lived that long. And so, I think we do them a disservice if we just dismiss them completely and we don't talk about the risk and benefits of screening and have a healthy discussion and share decision making. I'm showing you this slide because it's disturbing. We showed you the decreasing overall incidence of mortality from cancer across all age groups, but if you look at this demographic, or those under the age of 50, they are outside of our screening recommendations, and they actually have an increasing trend. And no one really knows why this is. Maybe the risk factors are present earlier in life, such as obesity or certain environmental factors, dietary differences. Perhaps we're detecting more because we have a better ability and more resources to endoscope people who have symptoms of lower GI tract problems such as bleeding. It's unclear, but I think that more attention to this may yield changes in the future about guidelines. So let's talk about a case, and I think I may have skipped over this earlier, I apologize, but you should have the answer now. This is a 77-year-old white male who comes to your primary care office requesting cancer screening for colon cancer. He denies any rectal bleeding or symptoms of anemia. He's fit and active. And if you review his past medical history, he has controlled hypertension. He takes a statin for LDL. He has BPH and he has psoriasis. There's no previous surgeries that might indicate he would be high risk for an endoscopic exam. And you review some basic labs and there's no anemia and his chemistry looks normal. So what do you recommend? So A, you could refer him for a colonoscopy, comply with his wish, and that's what he wanted. You could perform a rectal exam for FOBT testing in the office. It's quick and easy. You might examine him anyway for his history of BPH. You refer him for a CT colonography. You tell him colorectal cancer screening is not recommended, or none of the above, which would indicate you have another option. Maybe there's not a right answer. So if he's a Medicare beneficiary, it's unlikely that CT colonography would be covered and approved. So that may take that out of the equation. It's clear by now that fecal occult testing from a rectal exam is inappropriate, so you don't do that. Referring him for a colonoscopy would not be unreasonable. He's a healthy guy. He understands the risk and benefits. I think that would be a reasonable exam if you find an early cancer. The question is he a surgical candidate? And he very well may be. If you find polyps and they're small tubular adenomas of about 5 millimeters, it's a question of whether or not that would be beneficial. You could do standard fecal occult testing. That would be non-invasive, not a lot of drawback, and if positive, might indicate he's higher risk and you have a higher degree of benefit from an invasive exam. And then finally, he came to you wanting a screening, so he's kind of selected himself. But after you talk to him about the options and discuss bowel prep and these sort of things, he may not want screening. So what's on the horizon? Do we change the age for screening? Do we increase the age or decrease the age? And I think in either direction it's possible, particularly because of that troubling statistic I showed you with the increased incidence in young people, but also because our population is aging and we have patients that are actually healthy and older. So what do we do about that? And they may actually have a mortality benefit. It's just not been studied, and that's been the limitation for anybody to adopt any serious guideline changes. Do we make gender or ethnic group specific recommendations? So we mentioned African Americans at the age of 45. American College of Gastroenterology did actually recommend that, but it's not been adopted widely. Women, should women be tested later or should men be tested earlier? Again, those are things that have to be worked out. I think the answer to the next question, will fecal DNA tests become better? The answer is yes, they will become better. The question is, will they be cost effective and widely adopted and available? Will we ever have a sensitive stool or serum biomarker? That would be great, but it's not there. Can we improve colonoscopy quality? The answer is yes, and we should do that through improved training, whether it's through surgery programs or gastroenterology programs. So some conclusions. Colorectal cancer screening reduces both incidence and mortality. That's clear. Screening modalities should be chosen based on patient preference and factors and resources. So kind of the shared decision that we've been talking about. Colonoscopy provides significant reduction in colorectal cancer incidence and mortality in the distal and proximal colon. There were some concerns about that, but I think those have been allayed somewhat, and now we're trying to figure out how we can better improve protection in the right colon. Colorectal cancer screening programs need to address quality, which seems to play a critical role in the test performance. So poor quality colonoscopy doesn't protect you too much, and it could do harm in giving you false reassurance. Okay? So I just want to, since it's my first grand rounds, pay thanks to two of my mentors, Donald Castell, who I did a year of esophageal motility and reflux work with, and then Peter Cotton, who trained me to do endoscopy. And better than that, they're great individuals and a good role model for how to treat patients. This is a picture of a fountain in Charleston and a common place for people to go visit. So thanks for your time.
Thank you, Jason. Very, very helpful. So clarify for me the issue of the screening test, because in several slides it says, let's see what the preference of the patient and the doctor. In other slides it says you can use colonoscopy or the blood test. What do you follow?
Well, a screening test is only as good as the person that agrees to have it done, right? So that's the issue. Let's just, for argument's sake, say colonoscopy is the best screening test. And if you had your preference, you would just say do a colonoscopy in everyone. Well, there's limitations to that. There's not enough endoscopists in the country or the world. There's increased cost from that. There's increased risk from that. So from a population standpoint, having a less invasive, cheaper test to identify maybe higher risk people that could then benefit from that exam, I think that's a discussion that you have to have. Here locally in the Portland clinic, they take average risk or lower risk individuals aged 50 and above without GI symptoms or anemia, unexplained artificial anemia, and they perform fit testing. And if they have a positive fit test, then they send them over for an endoscopic evaluation. Okay, the VA uses fit testing as well. They both use different assays, but they're both in-house tests with less chances of affecting the test performance based on the patient's attention to details like not taking NSAIDs and vitamin C and that sort of thing. So I think you have to look at it from a population standpoint.
It does make sense to sort of screen people with a FITS test and then move on if it's done appropriately and you can follow them.
That's the thing. It's an annual test. It has to be performed appropriately to eke out that maximum benefit that's been shown in these studies. Okay, in real world though, it's not being done that way, and that's why if you have a quality negative colonoscopy, there's been data to show good protection out to 15 years, and that's attractive.
Yeah. And then I was going to ask you if there's a composite that has been evaluated, like if you take age, genetics, screen tests, and could that narrow down the people that you need to do colonoscopy for?
Yeah, I think based on the data with that broad distribution of cancer above the age of 50, a lot of people that come for their first screening at the age of 50 are asymptomatic, and they have a prevalent cancer that you find. So the problem with that is that there's a lot of asymptomatic disease out there, and we know that with this disease, early detection greatly impacts outcome.
Questions? Start here and then.
What percentage of age 50?
That's a good question. I don't know the exact number, but my guess would be that it'd be quite high. What would be really nice is to know from a patient profile standpoint who are polyp formers and who are not. Most of the non-invasive tests are really good at detecting high-risk polyps, so those are the ones with high-grade dysplasia, they're large, or cancers, okay? But they don't find these small lesions, and that's why they're repeated frequently. So it'd be interesting, we talked about adding fecal test in between screening colonoscopies. It would be interesting to adopt something like that for someone who had a very good quality negative exam at the age of 50 and then somehow reduce their need for frequent exams. But, there's a problem in the community, worldwide actually, that people have colonoscopies inappropriately too frequently or too soon. And people are ignoring the guidelines. So I think your point's well taken. I think there are people that are polyp formers and there are people that aren't. If we could somehow identify those people with a non-invasive test, that'd be fantastic. Yeah. Yeah. Right. Yeah. Yes. Yes, I think so. So to answer the first portion, if the patient had never been screened, they're coming for first-time screening, the guidelines would suggest that you wouldn't screen. But again, we talked about how if he's a healthy guy, 77, who knows what his life expectancy is, and maybe 85, 90, but you can talk about screening. And somebody that had a negative initial screening at the age of 50, if you're surveying those people, the recommendation would be that you would continue surveying and he would be due. But up to the age of 80, you're talking about discontinuing surveillance protocols for people that have had, small adenomas in the past. Again, because the mortality benefit tends to go down, because the adenoma carcinoma sequence for a small tubular adenoma is 7 to 10 years.
No questions? I was going to ask you one because we're struggling with the concept of screening in lung cancer as well. And sort of it's been narrowed down based on the guidelines of 50, 55 years of age smoker or ex-smoker in the past 15 years. But then there's a lot of data coming now, and even though Medicare has now accepted to pay for that, now there's data coming and say, well, wait a minute, radiation after this many years is probably worse. There are many false positives, that sort of thing. I didn't see a lot of information about safety problems, false negatives, and negative consequences of too much screening.
Yeah. So the issue...
Perforating a colon or something.
Yeah. So for the non-invasive test, the fecal test, you have significant false positive and negative results. And part of that has to do with the way the patient preps. But for a false positive result, it kicks you over to endoscopy. So that's where your risk increases. The risk, though, of a colonoscopy is less than 1%. And that could be, each time you get one, you're going to have that risk. The main risk is actually with the moderate sedation that's administered. The higher sensitive fecal cult tests, like the highly sensitive guaiac tests, have a lower specificity value as well. So that's an issue. CT colonography does have perforation rates because the patient has to have colonic insufflation with air so they can distend it and see lesions. So there is a reported perforation rate. And I think the biggest one is the finding of incidental things. And we see that all the time. Screening for lung cancer is a big issue, right? You find the incidental lesion, an adrenal adenoma or something, and then the downstream workup poses an increased risk. So cumulatively, if you're having endoscopy, that's probably the highest risk procedure, particularly when polypectomy is performed. But it also provides better risk reduction of cancer over the long term.
Well, you guys have a good day. Thank you so much. This was good. Great. Thank you so much. Very
Yeah,
good.
thanks.
Very good. So these presentations, you always worry that the audience start asking